And it's my pleasure to introduce Dr. David Kay. Dr. Kay is a board-certified eye physician and surgeon practicing in the Mesa and Scottsdale areas of Phoenix. Originally from Tucson, yay, go U of A. Dr. Kay completed medical school in Milwaukee at the Medical College of Wisconsin. After completing a transitional year internship with the Tucson Hospital Medical Education Program, he spent the next 3 years in Texas, completing his residency with UT Health San Antonio, where he served as chief resident during his senior year. He received his glaucoma fellowship training at the University of Southern California Roski Eye Institute prior to moving home to Arizona, where he currently practices. Welcome, Dr. Kay.
Thank you so much. Appreciate it. So can everybody hear me okay? Sounds like it's working. So, well, thank you again for having me. It's really an honor to be here. I was flattered by the invitation, so I hope you all find good use out of my talk. The talk I was asked to give is called Glaucoma 2023, Evaluation, Treatment, and the Future. And I have no financial disclosures related to any of the material in the talk. All financial relations have been mitigated. And again, thank you for that lovely introduction. So I did grow up in Tucson. I actually went to ASU though for a bioengineering degree. So I'm a little bit torn as far as my allegiances, but I went to Milwaukee, followed by San Antonio for residency. And then I did my USC fellowship in USC. And I think it gave me a nice broad background, a lot of different patient populations, and a lot of different experiences, which I think has really helped me along the way. I'm currently working for Arizona glaucoma specialists. I have a couple of locations, one in Mesa and then one in Scottsdale. And I actually come from a line of optometrists or of eye doctors. My grandfather was actually an optometrist down in Tucson. My father is actually a retired ophthalmologist. And then I'm currently working with my brother. He's a medical optometrist for our practice. We don't do any glasses. For those of you who have referred to us, you're probably aware of that. But he was invited to give this talk with me today, but unfortunately he couldn't be here because he's celebrating his 1-year anniversary. So he's in Spain right now enjoying himself, but he sends his regards. So we'll jump into the talk. We're going to cover some basics here in the beginning. As we all know, glaucoma is the leading cause of irreversible blindness. In adults over 50, it's estimated that 4 million people worldwide have moderate to severe vision impairment, and it accounts for 11% of global blindness. It's variable by nationality. The highest rates are those of African descent, followed by those of East Asian descent. And it's estimated that by 2040, 112 million people will be affected. So we're all aware of the huge burden that glaucoma takes worldwide. How about here in the US? It's estimated that 3 million are affected, with 2.7 million of those being open angle glaucoma. It's estimated to cost the US economy $3 billion every year. And the prevalence here in the US is highest in those of African American and Hispanic descent. And what's concerning is that half of all individuals with glaucoma in the US don't know it. So, in some ways, I actually have it a little easier because by the time patients arrive in my clinic, they're already either suspected of having glaucoma or they have the diagnosis. So many of you are working on the front lines and you're often seeing patients that maybe haven't seen an eye doctor in years or maybe their life. And you're tasked with diagnosing this disease that often has no symptoms. So, we're going to cover some basics here in the beginning, and it's important to keep a lot of these things in mind while you're trying to identify and diagnose and manage these patients. So we'll review some of the strong risk factors we're all aware of. Elevated intraocular pressure, of course, being the only modifiable risk factor. Family history, disc cupping, thin CCT, older age, especially African-American patients, those over 40, and then in the general population, those over 60, especially Hispanics. There's many other risk factors that have been teased out by lots of other studies. We're not going to go into these in detail, but it's important to keep these things in mind as we're getting to know our patients and we're trying to ask targeted questions. Of course, you want to take a full medical history, full surgical history, review systems, but when I'm focusing on a glaucoma history, there's a few things that I really specifically focus on. One being family history, but you want to know more detail about the family history. You want to know about the level of severity in the family. Did anybody need surgery? Did anybody go blind? A lot of patients have heard of a trabeculectomy because maybe their mom had it. Steroid exposure, both current and historical. Some patients might have had an autoimmune disease. They were treated for a couple of years, and they might have had skyrocketing pressures during that time and sustained damage, but now it's quiescent if it's under control. I want to really point out the nose sprays. A lot of patients have been prescribed daily nose sprays by their allergist or their ENT doctor, and they're not aware. If they're taking Flonase, Nasacort, they're not aware that these are steroids. I've seen a lot of patients that have had significant damage because they've been taking it every day for years, and the pressure's been in the 30s. So I specifically inquire about this. Lots of patients don't know that these are actually steroid treatments. And then, of course, any blunt trauma, even a remote black eye as a kid could come back, cause glaucoma, cataracts, retinal issues later on. What about our hyperopes, or if you're worried about angle closure? So, of course, the typical symptoms we ask about, headaches, especially frontal, sinus-like, any intermittent episodes of blurry vision, halos, etc. Their ethnicity can be a predisposing factor. And then until they've had the angles managed, there's a lot of medications that they should avoid, a lot of the glaucoma warnings for the over-the-counter meds. So these are important things to ask about. What about our normal tension patients? So these patients, I always specifically ask about their blood pressure medications. There are a lot of patients that are overtreated with their blood pressure medicine. And especially at nighttime, I try to have patients avoid, if it's okay with their prescribing doctors, avoid the blood pressure medicines at night. A lot of these patients will have nocturnal hypoperfusion of their optic nerves, and they'll progress no matter how low you get the IOP. And then, of course, you can ask about positional changes, which is also an indication of having low pressures. How about the exam? We're all aware 20/20 is still possible, even if you have a central island. So that doesn't really mean a whole lot. Pay extra attention in our high refractive error patients. It goes both ways for higher risk. And then don't forget, if they've had corrective refractive surgery, they still have an eye that might be structured for this predisposition for glaucoma. Goldman applanation is still the gold standard for IOP measurements. If you don't have access to Goldman, the IOP measurement should be taken with a bit of a grain of salt, and even more so if you don't have regular pachymetry access. That's to put the IOP into context. And again, the IOP measurements may be a little even less reliable if they have had LASIK, PRK, or if they have high astigmatism. So for my patients with high astigmatism, when I'm checking, I always check at the 90-degree meridian and the 180-degree meridian, and I'll take the average of the two. That's going to give you a much more accurate measurement of the IOP. So the pupil exam, this is important, obviously, to identify an RIPD, but I take this as an opportunity. If they have asymmetric disease and they have an RIPD, I'll show them which eye is the light's brighter, which eye the light's dimmer. That's a great opportunity to show your patients who was previously asymptomatic, teach them about their disease, and that will help you with your compliance moving forward. So as far as the anterior segment exam goes, these are some of the things that I put extra focus on. We'll go through these individually. I'll always have patients look down. I'll use the upper eyelid to move the superior conge around. I'll check for any signs of previous surgery. It's usually not this obvious, but you might be surprised what you'll find. This is not one of my cases, but this is. And this is a patient with a nice diffuse bleb from a fornix-based trabeculectomy. And sometimes these can be more subtle. We're trying to make our blebs a little more wide, a little more diffuse, and a little more vascular, so we get rid of those late complications like the bleb leaks and dysesthesia. So always focus on the corneal endothelium. Two things you don't want to miss as far as secondary etiologies: pseudoexfoliation and pigment dispersion. So I always look for a Krukenberg spindle, especially in those young, high myopic male patients, much more common. And of course, I think every patient should be transilluminated. You might be surprised to see TIDs, or you may find that they have UGG syndrome from a previous cataract surgery. You want to look at the pupillary margin, looking for, again, pseudoexfoliation. If they're diabetic, you want to rule out NVI. And once they're dilated, it's good to look at the anterior lens capsule again for pseudoexfoliation. Gonioscopy. So if you're wondering what this is actually looking into a half evaporated coffee mug, and it makes for great TM. Who knew? So which lens are you going to use? Personally, I like the Sussman 4-mirror. Everybody's got their different preferences. If you prefer to have a handle, the Posner is good too. You just want something that has a small enough diameter that you can do dynamic gonioscopy. I'm not going to get into the anatomy. If you need a refresher on your gonioscopy, the website gonioscopy.org is an excellent resource. That's what I used in residency training. But this is more to point out that this is not what your view should look like when you're doing gonioscopy. This is more what your view should look like. You need to have the rooms dimmed. You need a small, thin, dim beam. You're basically trying to simulate the most natural state of the angle. So really, you want to avoid passing any light into the pupil. You want to avoid any corneal pressure and anything that's going to artificially widen the angle. So if you've done your full exam, you've gone all the way around, you're still not sure about some of the anatomy, you can do a corneal wedge. Where the apex of the wedge is, that's where you're going to find your Schwalbe's line. And oftentimes, like in this case, you'll see a Sampolisi line. Don't be fooled by that if you're looking inferiorly, which is more often where it's present, because you might think the angle's more open than it really is. Then you can get into dynamic gonioscopy, checking for a double hump sign. And if I'm still not sure if it's a tough angle, sometimes I will at the end crank open the beam and really get a good view. You can see here some clear PAS. So considerations, the obvious one is to rule out risk for acute angle closure glaucoma. But I think what is undervalued is the risk for chronic angle closure glaucoma. Intermittent and chronic angle closure glaucoma are much more common, and I think they're often misdiagnosed. And I think that's even more important to look for in certain cases. So angle recession, of course, you want to look for. Neovascularization, heavy pigmentation. If there is pigmentation that's pretty heavy, is it asymmetric? That can be a red flag. And don't forget, in your pseudophakic patients, there might be evidence that they were narrow prior to getting their cataract out. So you might see PAS or other signs of their previously narrow angles. I don't favor any particular grading systems. I just describe what I see. And, if you're ever not sure, you want a second opinion, don't ever be afraid to refer. I'm always happy to see any patients under any circumstances. You should never feel intimidated or, feel as though a specialist is going to feel like, oh, why are you wasting my time? I'd never feel any way like that about a consult. CCT, a couple of the major studies showed that on average it's about 570 microns, and that the risk is less with a thinner cornea, less than 555. And keep in mind, there's still no accepted correlation factor, but eventually we'll probably start incorporating corneal hysteresis. It's not ready for prime time, but this will also likely impact our IOP measurements in the future. And then this is just from the Los Angeles Latino Eye study. We've probably seen this 100 times by now already. The signs of glaucoma, again, things that we all know. You get exposure to the lamina cribrosa, thinning of the rims, nasalization of the blood vessels, peripapillary atrophy. These are, of course, obvious cases. You ever see disc heme, that's a big concern for glaucoma. But if it's not quite as obvious, that's why we have OCT. So OCT uses the principle of low coherence interferometry, and often it precedes visual field loss. I use the Cirrus platform, so apologies to anybody who uses other platforms. But when I'm running through, of course, you want to confirm the name and date of birth. You want to confirm the signal strength is adequate, 6 or above, ideally. And then you have your main parameters here in the center. As far as the RNFL thickness, the average RNFL thickness, I consider 4 microns or greater to be significant change. That's based on this study. They looked at the tolerance limits for both the average as well as the quadrants. And, to be statistically significant in the quadrants, I usually consider about 7 or 8 based on this study, but 4 for the overall average. I like to use the qualitative data on the sides a lot for patient education. And it's just nice to visualize. And then the same thing with the T-SNP chart here. You can see that, for example, this patient shows clear superior thinning of the right eye's RNFL. And one pearl is that, with high myopes, you might get a temporal shift in this chart. So it's going to basically move outward. The peaks can be shifted. So you might see red disease, even though they might have nice, beautiful peaks. It's still going to show up as abnormal on these scans. So just be aware of that in your high myopes. And then you can use the quantitative data to track things progressively. This is not the same patient as above, but it's an example of the guided progression analysis. And so MAC OCT is also very useful. It can identify things sometimes even earlier than the RNFL. It's good, especially in patients that have abnormal discs or peripapillary atrophy that's creating a lot of artifact. So this is the same patient as on the RNFL above. So here, one thing we often see is what's called a temporal raphe sign. You see this linear streak temporally with the thickness map. And if you recall, above the OCT RNFL was actually normal for this patient. But if you look carefully here, it doesn't show up quite as well in the PowerPoint, but there actually is a temporal raphe sign in this patient as well. And so it also correlates with the deviation map down here. So, these findings can indicate that even though the RNFL looked pretty normal for this patient probably does have early disease even in the good eye. And of course, you get the rest of your quantitative data here in the middle. Keep in mind, we're not looking at the nerve fiber layer with the MAC OCTs typically. Typically, we're looking at the added sum of the interplexiform layer and the ganglion cell layer with these. So despite that, there still should be a correlation. So if you don't see a correlation between the two, look for answers for why that might be. Anterior segment OCT, very helpful in a supplemental way. It can reinforce your gonioscopic findings. It's helpful if there's corneal disease or poor patient compliance. It's really helpful for patient education, showing them what the concern is and why we're doing what we're doing. But keep in mind, typically we're just getting a cross section with these. It's not a dynamic process, and you can miss a lot of subtle findings that you can see on gonioscopy. And the main point is that it's not a substitution for proper gonioscopy. It's very helpful in a supplemental way, but it's not a substitution. Here's an example. This is a nice wide open angle. This patient actually has pigment dispersion, and you contrast that, of course, to a very concerning and narrow angle with high risk of occludability. Visual field testing, this is a lecture entirely on itself, so I'm just going to fly through some of the pearls here. Humphrey is still what's most commonly used out there. And of course, there's many limitations. It's a subjective test. There can be a lot of sources of artifacts. Sometimes you can be a little overwhelmed with how much information you have. And there's still no gold standard for confirming diagnosis or confirming progression. But it's certainly it goes without saying, has a high importance in our management of glaucoma. So this is what the typical printout looks like. And our bread and butter is with the pattern deviation plots down here. So if you're not aware of what this is doing, what the pattern deviation plot does is it takes the 7th most sensitive point in the entire patient's field, and it gives that a value of 0. And by doing that, it then takes the other points and will correlate them based on that initial 0 value. By doing that, you're getting rid of things like cataracts and more broad artifacts, and you're bringing out the more focal defects like nasal steps or arcuate patterns. The glaucoma hemifield test has some use, especially in identifying early disease. Basically, it uses a special algorithm, and it gives you a printout of one of these 5 options. I find the other parameters below it a little more useful. I like the visual field index. It represents the entire field. It starts at 100%, and then it can trend depending on progression. You can get a plot that looks like this. This is kind of a textbook example here, not one you want to see in your clinic, of course. But mean deviation is also useful for tracking progressively over time. Starts at 0, and then once you start getting to around -30, you're getting towards end stage disease. Pattern standard deviation, I don't find it quite as useful. It's more representative of focal defects. So the higher the values, the more dense the focal defect, whether it's a nasal step or an arcuate pattern. Once you go from for example, an arcuate to more of a global pattern, this can actually renormalize. So you just have to be careful of that if you're using it. The guided progression analysis, this can also be helpful. This was used in some of the major studies. And this is what the printout looks like. It's also useful for tracking progression. But again, there's no gold standard protocol or algorithm for confirming or tracking progression. These are all just tools to use in your tool chest. We're all familiar with the glaucomatous patterns. And this is a classic nasal step here. You have more of an arcuate defect here. And this is becoming more of a hemifield superior altitudinal. If I ever see this, though, the paracentral defects, I'm immediately thinking, is this a normal tension patient, or is this at least a patient with blood pressure issues? You'll see this in a lot of, at least in my experience, your elderly, frail female patients. Maybe they're bottoming out their blood pressures at nighttime. This is a pretty classic pattern. All right, well, let's get into treatment of glaucoma. As far as setting an IOP goal, this should always be flexible. It should never be rigid. There's so many factors to consider. These are all things that you want to take into account. So I'll usually just kind of incorporate all of these items, make kind of a 2-point ballpark, and then just work with that. And it's always subject to change. And you don't want to let patients get so tied up on it that they come in and they can't sleep for a week because they missed their pressure check the week before. I do like, if all things are equal, in general terms, the Delphi panel recommendations. So again, all things being equal, tentatively, I'll set kind of high teens for mild disease, for moderate disease, more mid-teens, and then low teens for severe. But if they have a Tmax of 66 and they're severe glaucoma, they might just need a pressure that's physiologic, and vice versa if they're more of a low tension patient. Lifestyle, of course, we all get a lot of questions on this. So things that I tell my patients, of course, healthy diet and exercise. But you want to be a little concerned if they're a heavy weightlifter or if they're doing a lot of yoga, head down positioning. These are going to cause fluctuations, and we hate fluctuations in glaucoma as far as their IOPs go. You don't want to overdo it with excess salt, but if they're normal tension, they might actually need a little more salt in their diet. They might need to get that blood pressure up a little bit. Caffeine is an important one. I've actually seen a number of patients that are big caffeine responders. They'll be going steady for a while, and then they'll come in one day and they've had 3 cups of coffee before 10 a.m. And you ask them what they did differently, and they'll tell you that. So I always tell these patients to avoid excess caffeine if they can, try to cut the amount in half, and that can be helpful. Don't want to overdo it on things like alcohol. Obviously, you want to avoid smoking just in general. Marijuana has not been shown to be helpful. It's not recommended by the AAO preferred practice patterns. Yes, it does briefly lower the IOP, though. There is some evidence that CBD actually raises the eye pressure. And there's some evidence that certain collagen joint supplements can raise the eye pressure as well. It's thought that maybe there's some TM stiffening with some of these products. We're going to fly through medical treatment. These are medications we're all familiar with and prescribe every day. I'm just going to highlight some of my pearls and what I kind of like to focus on with these meds. Of course, the mainstay is typically our prostaglandins. The thing I want to say about prostaglandins, I've seen a handful of patients that were started on prostaglandins at a really young age. And by the time I've seen them, they've been on these prostaglandins for sometimes decades. The periorbital changes can be pretty drastic. And from, like Dr. Funky said, I always try to put myself in their shoes. And so if I were to be prescribed a medication, if I had mild disease or ocular hypertension and I didn't necessarily need to go on a prostaglandin, first I'd probably prefer SLT. But as far as drops go, I'd probably take a carbonic anhydrase inhibitor. That's just my own personal opinion, but I've seen pretty drastic aesthetic changes in these patients that have been on prostaglandins for many years or decades. Just something to think about. Alpha agonists, the big thing, of course, is what's going to do harm. You want to be really careful with kids and with nursing mothers. You don't want to use it. It's not even a caution. It's just a don't use it, because that can cause CNS depression and you could kill a kid. Something we're all familiar with, of course. But you can get the CNS issues with elderly, frail patients too, and that's something that is not uncommon to see. So look for it. Beta blockers, of course, the big thing is heart and lung disease. But with this, if there is a concern, if they're normal tension glaucoma, if there's a concern for systemic hypotension, I'll keep repeating this. This is one that you don't want to use as first or second line. I like Alphagan or Brimonidine as first line oftentimes in these normal tension patients as far as medications go. And then the CAIs, I'm not going to talk about orals, but the big caution for me is corneal disease. If there's Fuchs, if they've had a transplant, I avoid these. It's not good for the corneal endothelium. Miotics, I still do use. Sometimes I'm surprised if there's a later stage patient that's just resistant to so many treatments, not a good surgical candidate. Sometimes I'll try miotics and you can actually get some good efficacy there. So it does have some utility, and obviously it's got a lot of side effects, and there's the 4 times daily dosing, but it's a tool. It's a tool to have available. We'll spend a little more time on the newer medications. The ROCK inhibitors, there's really no cautions with this. Maybe corneal disease, they're starting to say, but otherwise, the main thing is just the side effects, things that we've all seen. The rates of hyperemia, of course, very high with this medication. The verticillata can be visually significant. This is not something I've seen, but there are some case reports out there, so just something to be peripherally aware of. You can get this reticular epithelial edema. Again, not something I've seen. And then latanoprostene bunod, same precautions as the regular prostaglandins. It's got this extra nitric oxide donating moiety, and it's supposed to relax the TM and give a little bit of extra benefit. So recall that with the initial prostaglandins, it's thought to be mainly the uveoscleral pathway. So because of that extra function, it did show increased efficacy in the Voyager study beyond latanoprost alone. So it's a nice new medication to have available. Don't forget to, and I'm sure most of us do a good job of this, but sometimes I'm surprised patients have been on medications for years, and I'll have this discussion with them and they'll tell me that they've never heard any of these recommendations. So sometimes you may forget, but it's just something to emphasize to your patients, because it's really going to help with the efficacy of the medications if they're taking it properly. And then, of course, there's the preservative-free options. There's the combination options. I'm not going to get into detail on these. So let's talk about laser. This is what most of my patients usually think of when I talk about laser with them for the first time. So let's talk about laser trabeculoplasty first. ALT, I still do use ALT. It's obviously not first line, but in some patients that have had SLT and they're not responding, once in a while they'll respond to ALT. So it's just an extra option. But this was what initially started our laser treatments for pressure lowering. There is thermal damage with ALT. You really get 180 degrees and then another 180 degrees, and then you're done. But the glaucoma laser trial did show good efficacy. We sometimes forget this because it's not as common, not as commonly performed anymore. But it was shown to be more effective than timolol, so it's still out there. But of course, selective laser is our mainstay. I am going to talk a little bit later on about the most recent light results, the light trial, and it performed pretty spectacularly. So it goes without saying, it's our first line laser option. Laser iridotomy. There's been a little bit of a push against laser iridotomy, which I somewhat disagree with. I will talk about Eagle. I'm not going to be able to get into ZAP, but some of these studies have pushed towards maybe taking out cataracts early or doing less laser iridotomy. And I think there's certainly a case for that in certain circumstances, but laser iridotomy is such a safe and easy procedure to perform, and it can really go a long ways of preventing patients, again, not even so much from preventing acute angle closure glaucoma, but that chronic intermittent kind of insidious angle closure glaucoma. So I'm still a big proponent of iridotomy. Of course, it's usually used for when there's a relative pupillary block. That's the mainstay of its use. And we've all seen pictures like this of the before and after iridotomy. Again, I mentioned acute angle closure glaucoma, but just as important, risk of chronic angle closure glaucoma. You can get IOP reduction with laser iridotomy if it's done early enough. And then a big thing, again, that is not that is a little bit underestimated is the symptom reduction. I'm surprised how often I see patients come to me after their iridotomies and they say that, you know, doc, my frontal headaches have gotten better. I'm not having these sinus issues, and it can really improve a patient's quality of life. And I think this is also undervalued. But the important thing with this is that it's most effective before they start developing increased eye pressure, before PAS develop, and before glaucoma develop. Because once that's happened, yeah, you're going to be stuck doing other surgical options, taking out the lens, and potentially doing more invasive surgeries. I do also still use laser iridoplasty. It's not common, but there are plateau iris patients that are resistant to laser iridotomy that this is a great option for. If it's done right, this is a really good option. So essentially what you're doing is you're constricting the peripheral iris. You're getting that peripheral congested iris out of the angle, and you're drawing everything inwards to widen the angle. So again, if there's iris root crowding, plateau iris, it's a nice tool to have. CPC, I think Dr. Funke talked about this, so I'm not going to go over this in detail. You have traditional CPC, and then you have micropulse CPC. I used to do a lot of each of these in residency training and fellowship. I don't do it as often anymore. Micropulse is a little less aggressive, and this is what your probes look like as you're doing it. You'll do a treatment around the limbus, and there's lots of different permutations on application protocols. But the traditional, again, it applies more heat, there's more collateral damage, but it can be a little stronger. So this is reserved definitely for end stage or later stage eyes. Micropulse, there is some thought it can be done a little earlier. I don't do it myself. I don't have access to a micropulse machine at this time, but I would still avoid it personally in good seeing eyes. That's from residency experience. And then, of course, there's a lot of risks with this. You can do damage, but luckily the significant damage is pretty low. Don't forget about cataract surgery. So with cataract surgery, you know, you can get a millimeter or two just by taking out the cataract alone. It's probably proportional to how high you start. It's probably proportional to how narrow you start in those narrow angle patients. But equally important, you know, sloppy surgery can actually cause glaucoma. And I do have a handful of patients that I'm seeing that had a lot of cortex left over, or they have UGG syndrome. And, you know, these patients come 5-10 years later to me, and they have this pseudo-inflammatory process that can be very resistant to treatment. And so my personal thoughts on cataract surgery, I think, you know, at least a solid 10, 15, 20 minutes should be done. You really want to clean out that cortex as well as possible. You really want to take out the OVD, the viscoelastic, so they don't have a pressure spike the next day. Most cataract surgeons out there are very good, but there are some places that are a little more like cataract surgery mills, and you know, they brag about their 5-minute cases, and I see their patients again 5-10 years later. So that's just my my pro for cataract surgery. I'm not going to spend a lot of time on MIGS. You just had a whole lecture on it. There's a ton of modalities, and it seems like this is expanding every single year. Dr. Funke, of course, talked about iStent. Traditionally, this has been combined with phaco, and this is what the injector looks like. You'll see these on gonioscopy. This is, I think this is the Gen 2 here, and you'll see these from time to time. Schlemm's dilatation, there's a few ways of doing this. I'm a big fan of Omni. So this uses a hollow dilating catheter. You essentially get kind of a 3-for-1 mechanism, and it's shown good efficacy. Hydrus, I don't have experience with. It does have good results, but at some point you have to just use what you're comfortable with. And I think that there's a saying about being a jack of all trades and a master of none. I think at some point, if you just have to know what works for you. So this is Omni. Basically, you're inserting a catheter into the Schlemm's canal. You go all the way around 180 degrees. You can even do 360. As you're going, you're injecting this viscoelastic material, which gives you dilatation of the Schlemm's canal. And as you're coming out, you can also get a goniotomy as well. This is what the hydrus looks like. And this is what it looks like on gonioscopic view. There's a lot of ways of doing a goniotomy or trabeculotomy. Typically, we'll do about 90 to 120 degrees of TM excision. This can be done standalone or at time of phaco. And the one thing that we don't have available currently is the suprachoroidal space. CyPass was on the market. It was withdrawn because of concern for corneal endothelial damage long term. So that was withdrawn. But eventually, we'll hope to have another modality that targets the suprachoroidal space. I think there's a lot of potential there. This is what the CyPass looked like, and on gonioscopic view. This is called a mini eject. This is something that's being investigated, and more to come there. This is what it looks like on ultrasound biomicroscopy. So Zen is such a nice tool to have now, but I would not consider it MIGS. This is a bleb creating surgery. And so, the risks are such, basically they're consistent with any bleb creating surgery that we have, but it is less invasive than a trab or tube. So it is a nice option to have. It's a gelatin stent designed again for subconjunctival placement. Originally, it was designed to be delivered ab interno. And so, this is what the injector looks like, and it was designed for this ab interno approach. Most of us use it off label with an ab externo approach. And we've just, at least in my experience, this is a much easier and much more effective way to approach the surgery. So you can get a nice bleb elevation, even if you're not working with a lot of space. So this is a patient that had retinal surgery. They had poor conj. You can see there's actually a contact lens over the eye. They've got corneal disease, and yet we're able to fit in this nice elevated bleb in between the scarring with a Zen. So it's really a nice option to have. Again, pros: it's less invasive than a trab or a tube, requires less conj, probably lower risk than a trab or tube, but it also probably has higher rates of failure long-term over a trab, and it probably gets less IOP lowering than a trab, maybe versus a tube as well, although the comparative studies are still pretty early. And then, of course, ciliary body ablation. I talked about CPC a little bit. There's also ECP. This is not something that that I use, but you'll hear about this from time to time. It's basically doing ciliary ablation during cataract surgery. Let's talk about tubes. So we're all familiar with what a tube is and what they look like. The TVT study is what really gathered interest in tubes. This was a study that compared Barevelt 350s to trab with mitomycin C. And with this study, the rates of failure were higher for trabs, the reoperation rate was higher, and they had more early complications. But the big caveat with this study is that all the patients that underwent trabs, all patients in the study had undergone prior surgery. So, and that includes prior trabs. So of course, trabeculectomy is not going to perform very well if patients have already had a trabeculectomy before. So nonetheless, this did lead to increased popularity of tube shunts. There's a lot of different versions out there. The biggest trend with tube shunts, in my opinion, we're starting to see evidence that tubes should be placed, if possible, into the ciliary sulcus. Long term, the risk of corneal failure with tubes in the AC are higher, and that sometimes you can't get it into the ciliary sulcus, but if possible, it's always my first preference. So just be aware of that, because you might be seeing these patients in clinic and you might see an AC that looks completely normal. And then you have the patient look down and you see evidence that they've had a tube shunt. It's probably going into the sulcus. Sometimes these are put into the pars plana, but they have to have a really good vitrectomy in order to do that. But it's probably going to become more and more common. And here, likewise, this is another patient, had a previous failed Zen from another surgeon, and they've got a tube shunt that was placed behind the sulcus, but you won't see it unless you dilate. So let's talk about trabs. So trabs, we all know, create a new fistula, a new pathway for that fluid to flow into the subconjunctival space. They're cost effective. There's no hardware required. So I am a huge proponent of trabeculectomy. It seems like there was a push for a little while away from trab, and with all the MIGs and all the other options, I think the popularity of trabs went down. But sometimes with the MIGs, it's treating the surgeon and not the patient. So I think that trabs are still the gold standard of IOP pressure reduction if a patient's a good candidate. So because of the TVT results, they came up with the primary tube versus trab study. These were patients without prior incisional surgery. So they now compared Berovelt's to trab with mitomycin C. They've reduced the exposure to mitomycin in these patients. And now patients had similar failure rates, similar IOPs after 5 years, and trabeculectomy actually performed slightly better. They had fewer meds and a higher rate of complete success. So recent trends with trabs, I think the popularity is returning, but unfortunately, I think training and residency is becoming more challenging because of oversaturation with all these other MIGS devices. I feel very lucky that I had excellent trabeculectomy training in my fellowship and also under my father. And so I learned the old school and the new school, and I combined the two into my own technique. But more commonly, we're also doing these from what's called a fornix-based approach. So we're trying to create, rather than these focal blebs that are subject to late leaks or early complications, we're trying to make them a little broader and more diffuse, a little more vascular, and these are less likely to have late complications. So that's kind of one of the trends in trabeculectomy surgery. And again, as I said before, I think it's still the gold standard of IOP lowering surgery, especially if you need to get to a really low pressure. But ultimately, the surgical decision is going to come down to both patient factors as well as surgeons' preferences and experiences. So let's briefly talk about the future of glaucoma. So as I hinted at, I want to do this in kind of a question format. And one of the questions that's being asked now is SLT going to be first line therapy over drops? And yes, in the UK, it already is. Not the case here yet, but this is all based on the LIGHT trial. So this is the most recent results of the LIGHT trial. What this trial did is it looked at patients with ocular hypertension or POAG, randomized patients to SLT first or drops first. And the main outcome measure was quality of life, but they also looked at clinical efficacy and adverse events. So after 6 years, SLT performed pretty spectacularly. They had equivalent quality of life scores, less disease progression, fewer trabeculectomies, fewer cataract surgeries. It was more cost effective, and 70% of those in the SLT group were at goal without need for drops surgery. And that was after getting up to 3 SLT treatments over the 6 years. They did have a higher eye pressure after 6 years, but the thought is that this is because more of the patients in the drop initially group had trabeculectomies. And so that's where that artifact is suspected of taking place. So take home points. As Dr. Funke alluded to, SLT does not require a patient's adherence. It probably reduces IOP fluctuation. And, from my own personal standpoint, I do still offer drops or laser as first line, but I do have a slight preference for laser if the patient is on board for that. If they do choose drops, then I certainly will recommend laser as the second option before recommending a second agent. And, I think Dr. Funke alluded to this as well. Don't underestimate the effect of drops long-term on the conjunctiva. It also affects the patient's quality of life. It can also affect surgery if they need conj surgery later on. So they're certainly not benign. What about clear lens extraction in place of laser iridotomies? This is something that I would like to push back against to a certain extent. The Eagle study is where a lot of this trend has come from. And they asked the question, is early lens extraction effective, safe, and cost effective? This looked at a population of patients with PAC and PACG. They did not look at any suspects or anatomically narrow angle patients. These patients were newly diagnosed and they were randomized to lens extraction or iridotomies. So after 36 months in the lens extraction group, these patients had a lower eye pressure, they had fewer meds, they had fewer additional surgeries, and higher quality of life scores. And it was also shown to be more cost effective. So in their conclusion, they stated that clear lens extraction showed greater efficacy and was more cost effective and should be considered as first line treatment. So the problem I have with the Eagle study is that the results here are sometimes extrapolated to apply to any patients with clear lenses who may also need an iridotomy. The patients in this study had a mean age of 67 and a half. And I don't know about all of you, but most of my 67 and a half year olds have at least a little bit of cataract development. Again, these were mostly glaucoma patients. So by this point, as I said earlier, by the time they have glaucoma, yeah, iridotomy is not going to be nearly as effective. So yes, at that point, the cataract should absolutely come out. The mean IOP was 29, and they already on average had visual field defects. So again, we have to be careful what population we apply these data to. My take-home points, cataract surgery can be absolutely appropriate as first line if patients are older, if they have glaucoma, elevated eye pressures, but this cannot be extrapolated to apply to just removing clear lenses instead of doing an iridotomy. If they are younger, they're in their 40s or 50s, they still have a level of accommodation. I think in situations like that, the iridotomy is absolutely the preferred choice. Importantly, one patient in the study, and I think this is underappreciated, one patient in the study actually went into angle closure glaucoma acutely while they were waiting for their cataract surgery. And that was out of 211 patients. So if I had 1,000 patients and I was going to do cataract surgery on them, if I had 5 of those patients going into acute angle closure glaucoma, that would be a bad number. So that's another big point that I took from this study. So what about home monitoring? It's just a little bit of a slippery slope. I have a couple of patients that have this product, and this is the kind of thing that you'll see these patients come in with. This patient calculated the half-life of their measurements, and we joke about it, but this patient actually caught a pressure spike. This was a normal tension patient, and they showed that upon wakening, the pressures were in the high 20s. Presumably, this is an accurate measurement at 5:07 a.m. But so there are pros and cons. You could probably get better diurnal monitoring. I think there's a place for this. But big cons, if patients are obsessing about this and checking at home constantly, it's going to cause a lot of anxiety, and also it's going to really be a burden with your triaging staff. So, plus or minus, I will say that the 2 patients I have that do this are definitely my high anxiety patients. And so I don't know, we'll see. What about checking visual fields with some of these VR systems? There's a lot of products that are coming out. Humphrey is still the mainstay. There aren't any strong data yet to support any of these VR tests, but stay tuned. This is probably where things are headed in the future. What about genetic testing? So is this going to help us risk stratify our patients? Probably. I think there's going to be a place for this as technologies get cheaper and more widespread. Studies have shown that you can calculate a polygenic risk score and that gives you ability to identify higher risk patients. It's not widely available yet. It's not advocated by the AAO's preferred practice patterns, but I think it's probably something that will help us in the future. 23andMe actually has a little glaucoma section. I'd be curious if anybody does have a patient or has experience with this. I'd love to see what the results look like. It's again, I think this is coming. What about neuroprotective agents? Is this going to help us supplement our IOP lowering therapies? What do we mean by neuroprotection? These are basically treatments other than eye pressure control that prevent retinal ganglion cell death. We're all familiar with brimonidine having some neuroprotective abilities potentially. It's been shown in animal studies and then in the Logit study. Definitely in my normal tension patients, I will use brimonidine over timolol because of this effect, all other things being equal, but it would be nice to have some other options. And so they looked at memantine, and this is a medication that's used for dementia. And they did a couple of large controlled studies, and unfortunately it didn't pan out. There were no benefits. So this was a bust, but one thing that they're looking at is nicotinamide and pyruvate. Nicotinamide is it's a variant of vitamin B3, and it has shown some short-term potential, but long-term efficacy is still in question. So we'll see how the long-term studies come out with this. So just to conclude, as far as the evaluation for glaucoma, as I said at the beginning, a lot of these patients remain undiagnosed, and it's the duty of our profession to identify these patients and make sure they get treated accordingly. Taking a thorough history, performing a thorough ocular examination, and our data acquisition is what's going to lead to these diagnoses and appropriate treatment. The treatment options continue to expand, but the goal still continues to be pressure reduction. And in the future, we'll probably expand on these diagnostic and treatment modalities, and we'll see shifts in the paradigm of glaucoma management. So my references are listed